Okay, we're going to start this set of podcasts with a review of inflammation because I am not exactly sure where or if throughout the program you guys have learned the steps of inflammation. So inflammation is going to be discussed, but it's not necessarily going to be tested on to the specifics of which I'm going to describe it in this next little podcast, but I think it'll help us understand some of the processes that are going to go on in the various diseases we are going to discuss, as well as the reason behind some of the medications that we're going to give patients when they have an inflammatory process going on. So the first thing, just as a general definition or general rule, inflammation is that rapid, non-specific, meaning it's not aimed or targeted at any one thing in particular, process that's really a measure to protect the body, and it's in response to some kind of cellular injury, and that injury can be due to any number of things, okay? We know that there's lots of times when we end up with inflammation. The basic mechanisms that happen within inflammation is that you have some mast cell degranulation, and you need to remember that mast cells are the things that release histamine. So that's where it's going to become an important role when we get down to some of the immunity disorders and hypersensitivities. And there are many, many different disease processes where we actually give a mast cell stabilizer, and the whole purpose of that is to prevent this process of inflammation so that you don't have some of the negative consequences of inflammation. Although inflammation is a process designed by the body to help protect the body, it can also have some negative consequences. So the first step with an inflammation is typically this mast cell degranulation, and by releasing the things that are inside those mast cells, it actually activates 3 different plasma systems, which helps the release of various cellular components that are designed to hopefully take care of whatever the causative agent of that inflammation is. So the ultimate goal of inflammation is to deliver the white blood cells and platelets that are needed for repair, to fix whatever it is that went wrong. But the problem is that there's some negative consequences to that whole process of inflammation, and we'll talk about some of those as we go through the next few slides. This is just a picture to show you that once we have the release of those inflammatory mediators from that mast cell degradation, there are 2 processes that happen simultaneously. You've got the local response, which is going to be the vascular and cellular stages, which we're going to talk about in more detail. And then you've also got that systemic or whole body response, which is going to lead to the white blood cell functions and then that acute phase response. Both of these again happen at the same time, although we're going to talk about them as 2 totally separate processes just so that we get a better understanding of what's going on in what phase. So the first phase that I want to talk about is going to be the vascular stage. Okay, so this is what's happening within the vasculature at the area of injury. So this is wherever that process is initiating. So as a general rule, if you think about this stage kind of working like a soaker hose. That's why I have that picture there, which might seem a little bizarre that I have a picture of a hose right now, but hopefully as we go through these steps it'll become a little bit more clear as to why I want you to kind of have that picture in your head. So within this vascular stage, the whole purpose behind it is to increase the blood flow to the area of injury so that we can get the players there that we need to have there. And it's just within that local area of injury. So initially, the very first thing is very briefly a vasoconstriction. And it's important to keep in mind that it does happen. There is that vasoconstriction, but it is very, very short-lived. Okay? Then what happens after that immediate vasoconstriction is that the cells in that area are going to die. That's like those mast cells that we're talking about with the degranulation. The death of those cells is what's going to release the inflammatory agents that are going to invite the other cells to come play with us. After that happens and you get to this vasodilation stage, this is going to increase blood flow just to the site. Okay, this gets a little bit confusing because when I say increase blood flow, sometimes you want to think throughout the whole body, and I really just want you to think about localized at the site, because actually the blood flow in and out of that site is going to stop. Here's the soaker hose mentality, because we want to essentially gather the little army guys who are going to help take care of the problem, as well as localize the offending agents that might cause problems throughout the rest of the body. So you have that vasodilation, which is going to increase that blood flow to the site. That also increases vascular permeability. And anytime you hear that word, increasing vascular permeability, you need to think about that it's letting things in and out of the vasculature that normally aren't allowed. So essentially the walls of the vasculature become holy so that different substances can go in and out that normally wouldn't happen. One of the things that's going to escape the vasculature now is fluid, obviously, but more importantly, the proteins. And I know we've discussed quite a few other times that proteins are what drive that oncotic pressure, and proteins essentially bring fluid with it. So if the proteins are escaping the vasculature and are going into the area or the tissue surrounding that site of injury, fluid is going to follow it. Both of these things is going to lead to that stagnation of the blood flow that we were just kind of talking about. So within that process, I'm stagnating the blood flow at the site of that injury. It's vasodilated. I'm attracting a lot more fluid and a lot more cells to that area. But by having that stagnation, it's going to allow the body to clot, if that's what's necessary. But also, and probably more importantly, it's going to localize the spread of any kind of infectious microorganism there. So here's where that soak-a hose mentality really comes into play. The exudate can leak out, so that's the water from the holes in the hose, into that inflamed tissue. So there's less blood volume leaving that tissue. So any toxins that might have been released by the cell degradation or by the causative agent are not carried to the rest of the body to cause problem elsewhere within the body. Okay? When we think of cardinal signs of when we think of inflammation, I want you to think of 5 cardinal signs. And this picture, although it is fairly blurry and somewhat challenging to read, it really does a great job of depicting what is going on within this process and what you see. All of us have experienced inflammation. All of us have seen signs and symptoms of inflammation, so this shouldn't be anything new to us. We know we're going to get that redness and the warmth, and both of those honestly occur from that vasodilation that we were just talking about, because that vasodilation, that so hard for me to say that, soaker hose effect is leading to that vasocongestion right in that area. Then we're going to have pain, and we're going to have loss of function. And both of those things ultimately happen, again, because of that soaker hose effect, and it's due to the swelling. So your 5 symptoms is the warmth, the red, the pain, the swelling, and the loss of function. And I do like how the last pillar on here is a loss of function, and they no longer have their arms. And I also think it's hilarious that the swelling is the fat guy in the middle. So maybe this image will stick with you to some extent, and you'll be able to remember those inflammation if you don't already. And I think I just talked and cut off the last part, but don't worry, it wasn't anything important. So then the next thing I want to talk a little bit about is exudate. So exudate is all those things that are leaking out of the vasculature into the tissue. The exudate itself actually has some certain functions. Number 1, dilute the toxins, okay, because we know that there's going to be toxins that are going to be present within this, and that's going to hopefully help protect the cells. It's also going to carry the plasma proteins to the site of injury, and we need those proteins there because they have a restorative effect. And ultimately, it will help us carry away, the exudate itself will help us carry away any toxins, dead cells, debris, any other byproducts of this process of inflammation. And the way it gets carried away is it gets carried away through the lymph system. When we talk about exudate, we've heard these terms before, but there are different kinds of exudates. You've got your serous, your hemorrhagic, your fibrinogenous, I added a G there, but you can read it, fibrinous, there we go, and membranous and purulent. Some of them you might not have heard as much about as others, but serous is just the watery fluid. It's just the plasma that escapes. And it's just going to ultimately lead to some of that swelling. Not a whole lot of function within that. Then you've got the hemorrhagic, and this is when there's very severe injury to the tissues, and so the blood cells are able to leak out. Fibrinous is when there is a large amount of fibrinogen in the exudate. And just like you normally think of with fibrinogen, it's going to create that thick, sticky meshwork, much like a blood clot. It's just not a total blood clot. Membranous is going to develop just on the mucous membranes. And it's ultimately going to help corral any of the toxins, kind of like the fibrinous. That fibrinous is that thicky meshwork like we were just talking about, which is going to cause some of the toxins to stick to it. And then purulent, we've heard a lot about. That's obviously contains pus. And that pus is actually made up of degraded white blood cells, so the byproducts or the breakdown of the white blood cells, proteins, and tissue debris. But we obviously, when we hear that, we think infection, and that's because those white blood cells are present within that exudate. So let's think about a situation. We've got this woman. She's got peritonitis. Okay, she has a distended abdomen. She's got a low blood pressure, and she's got fluid that's in her abdominal cavity. After her surgery, she had a history of GI surgery. She's told to report any GI distress, as it may indicate adhesions. And we've all heard of adhesions post GI surgeries, right? When the bowel connects to each other. Why does that happen? And it happens in a lot of ways because of the exudates that are released with inflammation. So if you think about what types of exudate might be released in a situation like peritonitis, the initial one's going to be a serous exudate. Okay, serous is just that, remember, that plasma fluid, and it's ultimately there. It's going to help dilute any bacterial toxins that are in the belly at that point in time that might be leading to that peritonitis. You've got that soaker hose mentality going on, which is going to decrease the rate at which blood is going to be able to leave that inflamed area because it's escaping through the holes in the hose, which is going to decrease, hopefully, the risk of those bacterial toxins going out to the systemic circulation. So that's a good thing. But as so often the case with any positive compensatory mechanism within our body, there's a negative side to that as well. So the downside of that is that it's going to ultimately, or could ultimately, lead to that decreased blood volume, which will lead to her decreased blood pressure that she has going on right there. The next kind of exudate that's going to happen is going to be what's that fibrinous exudate. And again, we talked already that fibrinous exudate creates that thick meshwork like pattern that's going to ultimately trap any bacteria that's there, again preventing it from going into the systemic circulation, which is a good thing. But the bad thing is, this is why or where adhesions occur, because it is so sticky and so thick. It's ultimately going to allow the loops of bowel to connect to each other. So that's where your adhesions occur post-op in abdominal surgeries, is due to that exudate process. So hopefully that helps you visualize a little bit more in your head what's going on during that whole scenario with exudate and why it has certain purposes with the body. Okay, now we're going to go to the next part of the local response. We've talked about the vascular stage. Now let's talk about the cellular stage. And the cellular stage is a little bit more basic and not as complex, at least for me, to understand, because this is just really talking about the role of the white blood cells and how the white blood cells are going to enter that injured tissue. And we know that the purpose of white blood cells is ultimately to destroy any infective organism and remove those damaged cells from the system. Okay? The thing to keep in mind is that there was already some mediators that were released just by the cell death initially. White blood cells are going to release even more inflammatory mediators to control, hopefully, further inflammation and to aid in the healing process that we need to happen. And the picture you have here is just the different types of white blood cells. And we'll talk a little bit more about these on a few slides down. So ultimately, when the white blood cells enter the injured area, they have a couple of steps of how they enter it, essentially. And this is getting to a pretty detailed pathophys cellular level. And I don't often, when I teach pathophys, go all the way down to the cellular level. But I think in this instance, it does kind of help you understand the entire process. So there's ultimately 4 steps that are involved within this, and we'll talk about the 4th step on the next slide. But the first step is called margination and adhesion, and it's really just saying that the white blood cells are going to start to accumulate on the vessel wall where the damage is. And on the slide up there, that's where you see the pavementing. Okay, so they start accumulating right where the injury is. And they do that because the next step is immigration. You can see that neutrophil has kind of changed shape so that it can escape through the hole that's in that vessel lining. And by doing that, it's going to be able to then have its role of chemotaxis. And anytime you hear chemotaxis, you need to start thinking about that's the invitation to the party. So by doing chemotaxis, it's inviting other players to the game to help deal with the issue. And so that chemotaxis is where it's going to lead to the phagocytosis. And here we can see a little bit more detail of what's going on within the phagocytosis. Phagocytosis, again, was attracted by those chemotactic factors of the neutrophils. The neutrophils invited the phagocytes to the party. And their whole role and the whole reason why they are invited to the party is to ingest the foreign or dead cells. Okay? That's the whole purpose. Phagocytes are kind of, in my mind, these little Pac-Man-like creatures. The way that they work is that they will recognize and be able to adhere to whatever target organism that they've got. So that's the step one you see up there in that picture. And then next they start to engulf it into the cell itself, and then once they have gotten it into the cell, they fuse with the lysosomes. And I don't know how much you remember of your cell bio, but that fusion with the lysosome creates a phagolysosome, and ultimately it will burst. One of the things to keep in mind is that the way that phagocytosis typically works is something called opsonization. Opsonization. This is just when an antigen or an antibody, can be either or, is coated by a substance so that phagocytosis can work. So opsonization is something that can happen with certain medications to coat that antigen or antibody so that it will be able to have enhanced binding, so the phagocytosis works a little bit more quickly. One of the other aspects within this is these plasma-derived mediators of inflammation. There are three main ones that we're going to talk about. We've got our kinins, the clotting system, and the complement proteins. Kinins, the main one that I want you to know about, or that you'll probably hear about most, is something called bradykinin. And bradykinin is one of the mediators that ultimately has something to do with the pain of inflammation, because it actually interacts with the prostaglandins to create pain. And then its other main function is to just dilate the blood vessels so that you can have that slowing of the flow, as well as to increase the vascular permeability so that the cells can get in and out that need to get in and out to start the healing process. Clotting system, we should be very familiar with what's going on in the clotting system. It ultimately has the function of forming the clot. But the other thing to think in mind, because that clotting system has that thick, meshy, sticky kind of process to make the clot, that same process actually prevents the spread of infection or inflammation by keeping the microorganisms in the foreign bodies at the site of injury. Okay, so dual effect. I want to form the clot, but I also want to prevent the bad guys from getting out into the system. And then the last one of these is called the complement proteins. And we'll talk a little bit about the complement proteins as being a part of the process of the hypersensitivities in one of the other podcasts. But their main function is to ultimately invite other friends to the party to get whatever needs to be fixed. So they do the same thing as bradykinin with the vasodilation and the increasing of the vascular permeability, but they also promote white blood cell activity so that the white blood cells can do their job of adhesion and chemotaxis. And they also have a little bit of a role with phagocytosis and just helping that process along. Okay, so back to our pictorial of what's happening with the inflammatory mediators. We've talked about the yellow side, so we've talked about the vascular stage and the cellular stage. Talked a little bit about the systemic with the white blood cell response. We'll talk a little bit more about that in a second. But now let's talk about that acute phase response. So in this acute phase response, this goes more into how the white blood cells play into this. So with the white blood cells, once they get there, they're going to release these substances called interleukins and tumor necrosis factors. Both of these substances are ultimately going to lead to many of the systemic effects of inflammation, like fever, lethargy, aching. All of that happens as a result of the leukocytes releasing those two substances. So that's part of that acute phase response, when you actually end up with a systemic reaction. And if you think about, so many of our different illnesses will have those just generalized, basic systemic manifestations of fever, aches, muscle weakness, lethargy, tiredness. That's all as a part of the inflammation process. Okay? part of this process also works within the liver by the liver releasing fibrinogen and C-reactive proteins. Both of these substances will help target the offending agent for destruction. Okay, so obviously we know fibrinogen is important with clotting. CRP is as well, but they ultimately will bind to the pathogens so that they can help the process of phagocytosis along. Within this part, this acute phase response, it's not as immediate as the local responses. This typically occurs within hours and sometimes even as long as days of onset of the inflammation. Not typically going to take days to get it to start, but typically not as quick as when you've got yet that localized response to the inflammation process. Okay, so that's the acute phase. It leads to all those systemic manifestations. I think I've talked a little bit about left shifts and that I had a slide somewhere along the lines that would kind of maybe help visualize that process a little bit better. And this is the slide that I was referring to with this. This is how, when we did a CBC with differential, meaning that we were differentiating the different kinds of white blood cells, this is how it used to be reported to us on our lab sheets. It's no longer reported like this. They typically go vertical instead of horizontal, but this will maybe help you understand a little bit more about why we called it a left shift. So the top row with the bands, neutrophils, lymphocytes, monocytes, eosinophils, and basophils, the top row of that is your normal ranges, okay? Not infected, no big thing going on, whatever. That's just normally the breakdown that you're going to see. What you see below that in the next is what you might see in a bacterial infection. And you see where the bands were less than 1%. Bands are immature white blood cells. White blood cells have a fairly short lifespan, or the neutrophils in particular, where they typically last about 10 hours. So when we're fighting an infectious process, they need to constantly be replaced. If we cannot replace the amount of neutrophils at the rate the body needs, it will start to release bands, which are those immature cells, out into the system. So you can see on that second row of blue, the bands have increased from less than 1% to 5%. And then you also see that the neutrophils have gone from 55% to 75%. This is what's called a left shift, because the cells on the left side of the equation have gotten higher. That's what we're talking about. So when you hear the words left shift, you need to be thinking of a bacterial type infection. So let's talk about some of the other cells. If I have a viral infection going on, I'm going to see the lymphocytes increase. Okay? So where the lymphocytes are normally at 36%, you can see that they decrease to 12% in the infection, because it can only be 100% total. With the infection, I'm saying bacterial infection. In a viral infection, you will see the lymphocytes increase and the neutrophils decrease. Kind of makes sense? And then if we had some kind of parasitic infection or an allergic reaction, we're going to see the eosinophils increase. So the eosinophils are typically pretty low, 1 to 4%. If I have some kind of parasitic infection going on or some kind of allergic reaction going on, those cells are going to start to increase, and the others, the neutrophils and lymphocytes, will decrease to accommodate the increase in the eosinophils. I hope that that's starting to kind of make sense, because you will still occasionally hear us talk about a left shift, but if you hear left shift, think bacterial infection. Then the last thing on this one that's not really going to be too much of an impact on the things we're going to discuss in the rest of this content is chronic inflammation. But ultimately, that's inflammation that lasts for longer than 2 weeks. And it can be that granuloma formation or a keloid type scar. That's typically what you think of when you think of chronic inflammation. There are other aspects, but again, I'm not going to go into those too much on this in this podcast. If you have more questions about that in particular, we can, of course, discuss that in class. So that's going to end this section. I will be back coming up with some things, pathophys on immune response. See you in a bit.